Welcome to the second part of the 10 things you didn't know doctors and nurses are talking about at the bedside when you're not present. This is the second part of the video, and we continue with point number 6, family dynamics. Now, believe it or not, a big part of the communication process in intensive care between teams, but especially in handover between doctors and nurses, there is always a component of the handover where they talk about the family and the family dynamics of a critically ill patient. Now, this is important for you to know, especially if you are having issues in your family that the doctors and nurses involved in your critically ill loved one's care are aware of, and especially if those issues impact on your critically ill loved one's care. To give you once again an example, if your critically ill loved one has a partner but is not married, and your critically ill loved one and the partner are living together, the ultimate question would be, who is next of kin of your critically ill loved one? Let's say you, as the viewer of this video, are the patient's mother and you don't like your critically ill loved one's partner, but the partner wants to be next of kin and you don't think that the partner would act in the best interest of your critically ill loved one. When it comes to the point where consent needs to be given for further treatment or for any procedures that requires consent, the situation could inevitably bring up further issues, and health professionals are usually highly sensitive when it comes to these interpersonal or family issues and dynamics, and it's often a much discussed handover item. What you need to take away from this issue is that you, your family, and maybe your critically ill loved one's partner need to come to a peaceful solution that is in the best interest of your critically ill loved one. If you are having family issues, just forget about those issues while your loved one is critically ill in intensive care. Find a compromise who will be next of kin for your critically ill loved one, and make sure that it's someone who has your critically ill loved one's best interest at heart. Once you have found a suitable next of kin, and once you have your family issues laid at rest, at least whilst you're dealing with your critically ill loved one's illness in intensive care, the intensive care team will stop talking about the issue. Number 7. You and your family's perceived understanding of the situation. The intensive care team is talking about your and your family's perceived understanding of the situation when you are not there. What do I mean by that? By that I mean that whatever the doctors and the nurses perceive that you understand is really happening in your critically ill loved one's situation is being discussed when you are not there. It's discussed in ward rounds where the medical and the nursing teams are following up on your loved one's condition, progress and management plan. It's also discussed during handover from doctor to doctor and nurse to nurse. And what they are talking about is their perception of what you understand is really happening, and their perception is based on the level of questions you are asking, or if you ask any questions at all. It's therefore so crucial that you get as much information as humanly possible about the situation that your critically ill loved one is in. If you don't educate yourself quickly, and if you don't educate yourself succinctly, you will have a hard time in the big machinery that is intensive care. Why do the doctors and the nurses talk about your perceived understanding of the situation? Well, they talk about it because depending on what the intensive care team perceives, how much you and your family understands about the situation that your critically ill loved one is in, that's how they frame everything from that point forward. Just like I was talking about in number 5, the doctors will pre-frame the situation, and you can counter-frame and challenge the situation depending on your knowledge and your understanding of the situation. That's why it's so critical to educate yourself quickly. You also have to keep in mind that doctors and nurses in intensive care are like fish in water. What do I mean by that? What I mean by that is that they live and breathe intensive care. They live and breathe it through every pore of their skin. They are absorbed in it. Therefore, it sometimes makes it hard for them to explain things in a way that is understandable to people who don't know and don't understand the environment they operate in. Just like if you asked a fish what water is, the fish wouldn't have a clue. Ask a person what is air. Can you explain it? It's a bit like that in intensive care for doctors and for nurses. It's what they do day in and day out. The doctors and the nurses are not going into too much detail of what is really happening, and they tend to give you a bigger picture view of the situation, and they only give you detailed insight if you ask succinct and detailed questions. It's as simple as that. And depending on the type of questions that you and your family ask, you will be judged about your level of understanding of the situation. Also, keep in mind, doctors and nurses tend to be time poor in intensive care, as it is a busy and stressful place. Once again, the better your knowledge and, more importantly, your perceived knowledge of the situation, the more the dynamics swing in your favor, and the more bargaining and negotiation power you will have. Now, you might say, Patrick, this is ridiculous. The doctors and the nurses are there to help, and they are there to explain things to me. You are right. They are often helpful, and they often do explain things to you. But in how much detail they go depends on your ability to ask the right questions and your ability to leave no stone unturned. Finding the right answers depends on you asking the right questions. This is true in this situation, just as it is true in other areas in life. If you don't ask the right questions, the doctors and the nurses will perceive you as someone who doesn't know what's going on, or as someone who doesn't really has an interest in what's going on. And that perception makes it much harder for the doctors and the nurses to communicate with you and with your family. It also makes it much easier for the intensive care team to drive their agenda. I often see families of critically ill patients in intensive care paralyzed and overwhelmed by fear, and that often leads them to being passive. Don't be afraid to ask questions, and don't be passive. Show some interest, show that you have insight, and show that you are not afraid of asking the right questions and stepping forward. As I have explained before, do just that, and the perception of the intensive care team as well as the dynamics usually swing in your favor. Number 8. Perceived quality of life of your critically ill loved one. Perception is reality. I keep talking about perception. Why do I keep talking about perception? Because perception is important in your family's, and in your critically ill loved one's situation in intensive care. The doctors and the nurses are always talking and thinking about the outcomes and the prognosis of your loved one, and the ultimate perception of what your critically ill loved one's quality of life might look like in the future if your critically ill loved one survives intensive care. Why is it important for you to know that the doctors and the nurses are talking about the perceived quality of life of your critically ill loved one if her or she survives intensive care? It's very important for you to know because the doctors and the nurses in intensive care generally have no idea what your loved one's quality of life might look like after intensive care. Why do I say that? Just like I mentioned before, doctors and nurses in intensive care are like fish in water. They live and breathe intensive care. They generally don't have a clue what is happening on a hospital ward, let alone what is happening outside of a hospital once a patient has left intensive care. So, their perception of your critically ill loved one's quality of life in the future outside of intensive care is a perception of the reality they are living in. The reality the doctors and the nurses in intensive care are living in is the reality of intensive care. Once again, they don't have a clue what the quality of life looks like outside of intensive care. They may have an opinion, and they may well have a perception of what that quality of life looks like, but at the end of the day, they just simply don't know. Just because your critically ill loved one is in intensive care at the moment doesn't mean that he or she won't have any quality of life outside of intensive care in the future. I can once again give you a couple of examples. I once looked after a young man who was in his late 20s after he fell off a scaffold while he was working on his job. He ended up with severe head injuries, rib fractures and kidney failure. He was in intensive care for a good 3 months, and half of the time he appeared to be, quote unquote, half dead, where the intensive care team thought he wasn't going to make it. Fast forward, he eventually left intensive care, and by that time he was still not 100% fit, and he was still extremely confused, leaving us wondering whether he would ever go back to work and live a normal and healthy life. But as I mentioned before, doctors and nurses in intensive care don't have a clue what happens outside of intensive care. About 6 or 9 months later, there was this young man back in intensive care again, and this time he wasn't back as a patient, and he was back as a visitor. Not that he was visiting anybody in particular, and he was visiting the intensive care unit, and he just wanted to thank everyone in the unit that they saved his life, and he said that he was so grateful for what everybody has done for him. He also said that he doesn't remember a single thing, just a complete wipe out of memories whilst being in intensive care. He told us that he was back at work and that he is enjoying life and that he's getting married soon. What an amazing story. We don't get that too often in ICU, that patients come back and tell us how they went. But it's great if they do, because we simply lose track, and if they do, it makes our work complete. Now, here I've got another amazing survival story. Another example, there once was this 92-year-old gentleman who collapsed in his garden after a heart attack. His wife started to resuscitate him and perform CPR while the neighbors were ringing the ambulance. Fast forward, the 92-year-old gentleman got admitted to intensive care, and during a lengthy and difficult admission, the odds were against this man, and he was a fighter and eventually made it out of intensive care to the ward, with everybody thinking that he probably wouldn't have a fantastic quality of life to go back to given his age. Fast forward, about 3 months after this 92-year-old gentleman had left intensive care, his son came to visit the ICU just to let us know that his father was doing very well and that his father was well on his way to recovery. Once again, this is such great feedback to get from a doctor or nursing point of view. It's amazing to hear that sort of thing, and it's getting even better. About another 3 months or so later, the 92-year-old gentleman comes back to intensive care because he just had a follow-up appointment with his cardiologist, and he came to the ICU and he wanted to let everybody know that he's feeling very well, he's enjoying life, and he wants to let everybody know how grateful he was for what everybody has done for him. What a fantastic story, and this makes us as doctors and nurses feel so good in intensive care, and once again we don't get that sort of thing all too often, where patients come back and tell us about how they went. Now, those 2 examples are fantastic examples, and thank God those 2 patients are extreme examples, but everybody in the intensive care also thought in both examples that the patients weren't going to survive, and if they were going to survive, they would have no quality of life. That was based on our perception of reality as fish in water. So, what exactly then is quality of life? You and your family need to ask yourself that if your critically ill loved one in intensive care is going to survive their ordeal, what his or her quality of life would look like, and is he or she prepared to live with a lesser quality of life. That lesser quality of life could be an intermediate step to a normal quality of life in a few months' time, and it could also mean that your critically ill loved one will have a diminished quality of life. But what is important? Is it important to spend time with your loved one after discharge out of intensive care, even if quality of life is not as good as before? The answers to those questions must be answered by you, your family, and by your critically ill loved one if he or she is able to answer those questions. It's not for doctors or for nurses in intensive care to make those judgment calls. They don't have to live with this decision. It's you, your family, and your critically ill loved one to make that decision, which is based on your perception and not on the doctors and nurses' perception in intensive care. Let's come to number 9 that doctors and nurses are talking about when you are not present at the bedside. Number 9 is end of life, or the elephant in the room. Yes, end of life is the elephant in the room in intensive care. Even though the statistics suggest that approximately 90 to 94% out of all intensive care admissions leave intensive care alive, approximately 6 to 10% leave a lasting and often literally life-changing impact on everybody involved when they die. First, let's quickly go to the statistics again, and statistics from the ANZIC's 2010 report, Center for Outcome and Resource Evaluation Annual Report 2010, confirm these numbers, and they pretty much apply to other countries as well. Approximately 6 to 10% out of all intensive care unit admissions do not leave intensive care alive. That means, statistically speaking, 6 to 10 admissions out of 100 admissions do simply not make it. Those are the facts and numbers. What does that mean in the real world? Well, it means that number 1, your critically ill loved one in intensive care has a relatively high chance of survival if admitted to intensive care. Number 2, it also means that should your critically ill loved one in intensive care fall into the 6 to 10% category, it is a traumatic, devastating and literally life-changing experience. End-of-life situations in intensive care tie right in with all of our previous points, where I gave you an understanding and insights about what is happening behind the scenes and what doctors and nurses are talking about without you being present. Furthermore, what is being talked about when you are there is largely dependent on your understanding of the situation, on the questions you ask, and it's also largely dependent on the doctors and nurses' perception of your understanding of the situation. Now, the same goes with end of life. If your critically ill loved one in intensive care is going to die, you may have already figured that this is what is happening. But in some end of life situations, especially in lengthy and delayed end of life situations, and by lengthy and delayed end of life situations, I am talking about situations that can range from days to weeks and sometimes even months. End of life situations where your loved one is dying fast are different. By fast I mean within a couple of days or even within few hours after admission to intensive care. In those situations, the doctors and nurses would be very straightforward, as they tend to see this coming very quickly, and they would be upfront and straightforward so that you can brace and prepare yourself and your family as much as humanly possible in such a devastating situation. In a situation where your critically ill loved one in intensive care approaches the end of life over sometimes many days, sometimes many weeks, or sometimes even many months, is a very different situation. There may be a turning point, and this turning point may not be obvious to you and your family as yet. The intensive care team tends to know or see this turning point. This turning point could be a new diagnosis, such as a heart attack, a bleed, a new pneumonia, or it could just be the look on your critically ill loved one's face. Most doctors and nurses in intensive care who have worked there for a considerable length of time can usually tell if a patient is going to die or not, because they have seen it before. And I can tell you that besides the doctors and nurses in intensive care talking about a particular patient dying, the mood generally swings in an intensive care unit. If there is a patient dying, especially one that has been in intensive care for a while, and everybody knows about the patient, the mood swings and a big cloud hangs over the intensive care unit, and everybody tends to be very sad. That doesn't mean that the doctors and nurses aren't sad if a patient gets admitted to intensive care and passes away within a few hours or few days. But it's different, as the emotional connection and the bonding is usually not as strong as with a patient and a family that they got to know well. But I can tell you that every death in intensive care is a tragedy for the patient, for the family, and for the intensive care team as well, hands down. So, once again, if your loved one has been admitted to intensive care, and maybe they have been there for a while and your loved one's condition is not improving, your job is to find out what's going on. Find out what the doctors and the nurses really think and really talk about when you are not there, because they have a good sense of whether your critically ill loved one in intensive care is going to survive or not. Maybe you know it already because your gut feeling is telling you. If you don't know, and if you are in limbo, find out what the doctors and nurses aren't telling you verbally, and maybe they are telling you non-verbally. Do you think that the doctors and nurses aren't going to tell you that your critically ill loved one in intensive care is approaching their end of life because they think that you and your family wouldn't cope, or you and your family wouldn't understand? Furthermore, the intensive care team might be talking about a strategy on how to approach the topic and the end-of-life discussion with you, with your family, and with your critically ill loved one, if he or she is awake and understands what is happening. Those are difficult, challenging, and often heartbreaking discussions to have, and if there is time and your loved one isn't suffering, that is a relatively good position to be in to approach the topic slowly and gently. But once again, I can't stress enough that the more information you have, the better it is. Know that if your critically ill loved one in intensive care is approaching their end of life, that the doctors and the nurses already know, and that this is part of their daily handover and daily routine. Your job is to find out about it and deal with it. Unfortunately, you can't run away. However, you can face it and stare death in the eye, literally. That which you fear and you don't face controls you. That which you fear and you face, you can control. Don't jump to conclusions. Sometimes a grim look on a doctor or a nurse's face is just that, a grim look. It may have nothing to do with your critically ill loved one. Health professionals in intensive care tend to be stressed, and the grim face might just be a result of dealing with a stressful and difficult situation with another patient or with another family. And keep in mind, you are stressed too. So don't jump to conclusions or overanalyze. Just try and gauge the situation, and most of all, ask the right questions and try and read the people around you. Number 10, and our last point. Doctors and nurses are talking about bed status, bed movements, new admissions, and how it applies to your critically ill loved one's situation. I have briefly touched on these in point number 5, where I talked about management of the ICU budget and how it might impact on your critically ill loved one's treatment. So, any intensive care unit has a limited and often fixed number of beds to allocate. As a rule of thumb, intensive care beds are scarce and are in demand. There are some ICUs worldwide that often can't admit patients due to a lack of beds, or sometimes they might have a bed and they don't have any staff. To put it more succinct, ICU resources are a scarcity. So, when the doctors and the nurses are making any predictions about your critically ill loved one's future or prognosis, one way or another, the overall situation of the intensive care unit comes into play. This can be said when it comes to discharging your loved one to the ward, and it also applies when it comes to end-of-life situations. I have seen more than once that end-of-life situations have been rushed and hastened, and suggestions of withdrawing treatment have been made with the knowledge and with the pressure that other admissions needed to get into the ICU. On the other hand, if your loved one is on his or her way to recovery, and if he or she is close to being discharged to the ward, a decision to leave intensive care earlier is more likely if the ICU is fully occupied and there are other patients waiting to get in. Once again, ICU resources are a scarcity, and that tends to be the limited number of beds and sometimes the limited number of staff as well. I'll give you another example so you can get and understand what might be going on behind the scenes. Your 84-year-old mother has just been admitted to intensive care with a rupture of an aortic aneurysm. Your mother hasn't been all that well, and your mother was going to see a doctor, and she left it until it was too late, and she collapsed, and luckily your mother's neighbor found her and she got admitted to hospital. It was found that she had a life-threatening rupture of her aorta, which is the biggest vessel in the human body. By the time of admission to hospital, she had already lost a fair amount of blood and she went for emergency surgery. After the difficult surgery, which took about 9 hours to stop the bleeding and repair the vessel, your 84-year-old mother got admitted to intensive care. She has been very unstable from the beginning, as she obviously has lost a lot of blood, and she also had a large amount of blood products reinfused in order to have the lost blood replaced. Your mother has also developed an irregular heart rhythm during surgery that has caused her heart to fibrillate, so that she had to have an electrical shock during surgery to get her heart back into a normal rhythm. Your 84-year-old mother has also gone into kidney failure. Due to the length of time, the kidneys haven't received sufficient perfusion during surgery. Therefore, your mother is very unstable, not only because of the massive blood loss, but also because of the irregular heart rhythm that needed to be treated with an electrical shock and a defibrillator. Your mother has a long-standing cardiac history, leaving her short of breath at times, and she's taking regular medication for her heart. Her quality of life has been better, but she is still relatively independent and she gets around the house without any help, and she can still do her shopping. Your mother has been admitted to a relatively small intensive care unit with 10 beds on a Friday evening. On Saturday morning, you see your critically ill mother for the first time in intensive care, and you can see that she's ventilated and that she is in an induced coma in order to keep her comfortable. You are holding her hand and you keep talking to her even though she's in an induced coma to keep her comfort and company. You can also see that the intensive care unit is very busy and that there are patients in all beds. You don't think much about it as you are too stressed and you need to adapt to this new and challenging situation. During the bed meeting in the morning, the nurse in charge and the ICU consultant or doctor realize that with a fully occupied unit and a lot of sick patients, that by Monday morning the ICU will still be fully occupied. That would mean that Monday morning's operating theatre list with 5 admissions requiring an ICU bed would unlikely fit into the unit, and some theatre cases would likely need to be cancelled, with the patient's surgery getting delayed until further notice. Before starting the ward round, the intensive care consultant wants to see the patients who are the most stable first, which puts your mother last on the list of patients to be seen. The intensive care doctor and his team have seen 9 out of 10 patients, and they are now finally coming to see your 84-year-old mother. It's already 1 p.m. lunchtime. The intensive care team has realized by now that the ICU is full of very sick patients with a high level of acuity and very few patients likely to leave the unit by Monday morning. The intensive care team also has Monday morning's operating theatre list in the back of their mind. They also know that it's winter time and that unexpected admissions can come up any minute. They also know that for the rest of the week, theatre is going to be very busy with more surgical cases requiring an intensive care bed. The intensive care team is now finally seeing your mother, and by the time the team approaches your mother on your mother's bed space, and after they introduce themselves to you, the intensive care doctor is going to ask you to leave so that they can do their ward round and do their investigations and examinations. You leave the bed space and you go back to the ICU waiting room, anxiously awaiting any news. After about 20 minutes into the ICU team examining your mother, after looking at all blood results and x-rays, as well as after considering your 84-year-old mother's pre-surgery condition, the intensive care doctor is asking his team of what they think the best course of action would be in order to keep your mother's best interest at heart. Well, the intensive care team is trying to decide the best course of action, and they have the fully occupied intensive care unit in the back of their mind. Some of the more junior doctors think that treating your 84-year-old mother full steam ahead would be the right approach. Another, more senior doctor suggests that talking to the family first to get a better understanding of what your mother was like before surgery might be advisable before making any further decisions. The nurse in charge also suggests that talking to the family first would be a step closer in the right direction, as everybody at the bedside agrees that an acute aortic aneurysm rupture with complicated surgery at your mother's age is unlikely to be straightforward, and a full recovery might be questionable. During the ward round, the intensive care team also discusses your mother's kidney failure, which appears to be at the forefront of concerns. Your 84-year-old mother's bleeding is under control at this point in time, and your mother's heart is beating normal as well. However, the biggest concern at this point in time is the kidney failure that either would need to be treated straight away, as your mother hasn't passed any urine since midnight and her blood results show that her kidneys have deteriorated massively. The next logical step from an intensive care perspective would be to treat your mother's kidney failure ASAP. However, the intensive care team also thinks that treating kidney failure with hemodialysis only prolongs the inevitable. From experience, once hemodialysis for kidney failure has been commenced, it would be more difficult to suggest a withdrawal of treatment from there, since first steps in the direction of treating the full clinical picture of your mother would have been undertaken. After the intensive care team has finished the ward round at your mother's bed space, one of the more junior doctors comes to see you in the intensive care waiting room and suggests a meeting in the next hour or so to fill you in what is happening and to give you an understanding of what the next steps may be. Ideally, you would like to have your spouse and one of your siblings to be there, and you quickly phone your sister again to find out if she can come into hospital as well. You are not too worried about your own family, as you know that your spouse is taking care of the kids and that it'll be fine. Half an hour later, your sister is coming, and 10 minutes later, the intensive care team with the ICU consultant, the nurse in charge, and another more junior doctor comes and sits down with you in one of the family meeting rooms. The room has no windows, one table and plenty of chairs, and it also has a couple of painted pictures on the wall. Now, the intensive care team has serious business to talk about. The intensive care consultant opens the meeting by giving you a quick overview of what has happened in the last 24 hours, and he explains what has happened during surgery and so forth. You understand most of it, and you do realize that your 84-year-old mother is very unwell and acutely sick. You do also understand that this is serious business, that it's life-threatening, and that your mother could well die from this event. The intensive care consultant continues to say that his major concern at this point in time is that your mother has developed acute kidney failure and that she hasn't passed any urine since midnight, and that if the intensive care team didn't treat her kidneys in the next few hours, further unwanted complications might develop. The intensive care consultant also explains that from experience he knows that patients with similar admission scenarios at your mother's age to intensive care usually do not do very well, and they sometimes die or they stay in hospital and intensive care for long periods of time. He then continues to ask of what your mother's quality of life was before surgery, and what you and your sister think your mother would want in an event and in a situation like this. Even though you realized how difficult and how serious the situation is, you swallow hard and you feel a bit teary, but you can hold your tears back for now. You can also see that your sister can't hold back her tears. You respond that you, your sister and your mother had never had any discussions about what should or would happen in the event of a critical illness. You sigh, and now you can't hold back your tears any longer. There is an awkward silence in the room for about a minute before the intensive care consultant says that he feels pressured to make a decision whether to treat your 84-year-old mother's kidney failure in the next few hours or not at all. He says that not treating her kidneys would complicate things even more, and he has concerns that if he does treat her kidney failure, that the intensive care team might be able to prolong your mother's life, but to what end? I stop here for a minute before we go back into the conversation. So, here you are. You and your sister have been presented with the clinical facts, and you have been presented with two options. Number one, treat your mother's kidneys with relatively slim chances of survival, and obviously nobody knows what the outcome is going to be. The doctor also mentioned that at your mother's age, recurring and permanent kidney damage might develop with regular hemodialysis requirements. The other option presented to you and your sister is to withdraw treatment and let nature take its course. When the intensive care doctor is talking about the option of withdrawing treatment, you and your sister start crying inconsolably. After a few minutes of crying, you regain your composure again, and you say, while looking at your sister, that you wouldn't want to make a decision one way or another right here on the spot, and that you would rather treat the kidney failure as a starting point until you and the rest of the family have come to a conclusion. You and your sister are feeling overwhelmed. You ask your sister how she feels about the situation, and she confirms that she feels similar to what you feel is the right thing to do. You feel the gravity and the burden of the situation. You ask the intensive care consultant what he thinks the right course of action is. The intensive care consultant is staring on the floor for a minute before he looks you in the eyes and says that he feels it's in the best interest for your mother to limit or withdraw treatment and let nature take its course. He doesn't feel that going through a lengthy period of prolonged treatment in intensive care is a worthwhile achievement, as the outcome is uncertain. The intensive care consultant also stresses the fact that people at a younger age, as your 84-year-old mother, don't recover well from aortic aneurysm ruptures, or don't recover at all. He, of course, doesn't mention that the intensive care unit is currently full and that they are also expecting 5 new admissions on Monday. You don't feel pressured one way or another. However, you do feel like the intensive care consultant and the team gravitate towards withdrawal of treatment and letting nature take its course. I stop this fictional conversation here, and I hope I have given you a snapshot and some insights into what other factors might weigh into difficult conversations like that. I don't try to put too much judgment on the situation, as I know both sides of the coin very well, and on the one hand there are the bed and resource pressures in intensive care that are day-to-day reality, and on the other hand there are the critically ill patients, more often than not unconscious and unaware of their situation, leaving the critically ill patient's family often in an extremely difficult situation where they feel overwhelmed and unsure of what is about to happen. I have seen these meetings and similar discussions over and over again, and the bottom line is that in the event that you feel like you need to make a difficult decision like I have just presented in this case, you need to ask for time. You of course can and even should ask the questions regarding bed and resource pressures in the unit to get a better feel of the situation. You can make your own judgment based on how the intensive care team reacts. Those situations are also very often not black and white, like sometimes painted by the intensive care team. In this particular situation, you might need more time because you need to get other family members involved in the decision-making process. Very rarely have I seen that families have agreed to withdraw treatment on the spot before asking for more time to think about the situation. What's also important for you to know is that in our case study, where an 84-year-old lady suffers from a massive aortic aneurysm rupture, the odds are probably against this lady, as I have seen many difficult recoveries after aortic aneurysm ruptures or leaks. However, there is always the one who gets through against the odds. As I have mentioned before, don't let anybody put pressure on you making a decision right here and there. Take your time and ask the intensive care team to start treatment until you have come to a conclusion. And last but not least, always listen to your gut, because your gut never lies. I really hope that this video has served you well, and I hope that it answered some of your questions already. For more information on a variety of topics within intensive care, check out more of our ebooks or videos, and also read our blog for more tips and strategies, and also check out our Your Questions Answered section, and you can find the links in the ebook or on our website. You can also send me an email at any time to support@intensivecarehotline.com if you have any more questions. Thank you so much for watching this video. I really appreciate your time. Thanks again, and this is Patrick Hutzel from intensivecarehotline.com, and I'll see you again in another update. Thank you.